Hello everyone, so let's start today's case study. So a 45-year-old male with history of non-insulin dependent diabetes, 5 years presence to the eye clinic for his annual visit. He complains about progressive blurring of vision since his last visit 1 year ago. Reading street signs while driving seems more difficult. He is unsure of which eye seems worse. He does not wear any glasses or contacts, exception of over-the-counter reading glasses. He denies any flashes or floaters, diplopia, eye discomfort, or pain. He also reports about his 6-month stress condition and his blood sugars have not been under good control, and he feels he has been making this worse by eating a lot of junk food and not always taking his diabetic medications. His blood sugar has been as high as 400 and he was admitted to the hospital 3 months ago for diabetic ketoacidosis. There is no significant ocular history, no ocular medication. But yeah, his past medical history is quite important in this case. He is having diabetes since for 5 years, as well as hypertension, hypercholesterolemia, and obesity. Alright, so his eye examination is, both eye visual acuity is 6/12. His intraocular pressure 15 and 15 respectively. That is pretty normal. No abnormality in pupil extraocular movements is full. Anterior segment slit lamp examination is also normal. However, in fundus examination shows some points to be noted. In his right eye, there is hard exudates greater than 500 microns, neovascularization of disc, multiple dot blot hemorrhages in the retina periphery, in all 4 quadrants. Retinal detachment. In left eye, fundus examination is showing microaneurysms, and hard exudates greater than 500 microns, away from the fovea, no clinically significant macular edema. Again, multiple dot blot hemorrhages in the periphery in all 4 quadrants. So over to you, pause the video and think about the answer. So, let's have a look on diagnosis. This the case of proliferative diabetic retinopathy. Retinopathy due to diabetes can be classified as non-proliferative diabetic retinopathy, absence of new vessels, or proliferative diabetic retinopathy, presence of new vessels. In non-proliferative diabetic retinopathy, also known as NPDR, the high blood sugars disturb the normal retinal vascular, especially capillaries, causing the formation of microaneurysms, and ghost capillaries. Weakened capillaries have the tendency to bleed. This is seen clinically as microaneurysms, dot blot hemorrhages and hard exudates. NPDR can range from mild to severe, and roughly 40% of patients with the severe form will develop proliferative diabetic retinopathy within 1 year. The proliferative diabetic retinopathy, also called as PDR, is defined by the development of small abnormal blood vessel neovascularization on the surface of the retina or on the disc or near to the optic disc. These are the results of high levels of vascular endothelial growth factor VEGF, released by ischemic retina. These new vessels are also fragile, and can cause significant vitreous bleeding. PDR is responsible for the majority of vision loss from diabetes. The vision loss is due to recurrent vitreous hemorrhages, and tractional retinal detachment. This type of retinal detachment is a result of the contraction of fibrous tissue, which accompanies the new vessel formation, and is difficult to surgically repair. Examination. Since diabetic retinopathy is the leading cause of blindness in working age, it is very important that individuals with diabetes have a dilated fundus exam at least yearly to monitor for diabetic retinopathy. The most important factor in the development and progression of diabetic retinopathy is blood sugar control. Tight control is associated with reduced likelihood of vision loss from diabetic retinopathy. Diabetic patients are recommended to keep HbA1c under 7 to decrease the likelihood of retinopathy. Hope you have learned something new today and found out staying. That's it for today. Stay connected till next video. Thank you.